Basically, we're trying to understand in this webinar the lymphatic system, the adipofascial disorder, which are fat disorder, lipodystrophy, lipedema. Okay, look at this beautiful lymphatic system. That's what I never learned in med school. This is a picture that's really, really beautiful that I use a lot. Just to remind you, it was discovered in 1622. So about 1628 is when William Harvey discovered the functioning, the physiology of the heart, the blood circulation. We discovered the presence, the mere presence of the lymphatic vessels in 1622. And the Greek mentioned it. They talk about some white veins. You have the lymphatic temperament with Hippocrates. But really, Gasparo Aselli did a dissection in Padua in Italy, dissection of a dog, and saw these beautiful milky veins. He called them the milky veins, what later on we're going to call the lacteals. We use that word. The Greek thought there was circulation of milk in the body, but Gasparo went a bit further and tried to dissect it and find an amazing system. Next day, he opened another dog and found nothing. So he had the ability or the genius to remember the first dog as a huge meal. And what he did, he gave a big meal again to the third dog and saw the lacteals again. And he realized there's something to do with the food coming for alimentation. And he did these beautiful plates. And those are the first color plates anatomical book in Europe ever, actually. This is, as far as we know, that's the very first anatomical plates in color. And if you see in white, you have all these beautiful lymphatics, the mesenteric lymphatics, and they all converge to L. Anybody can tell me where do they think the lymphatic were converging at the time? Any idea? Let me see if I can see that. Yeah. Any idea what organ is L? Where these lymphatics were converging for the anatomist of the 1600? It's a pancreas. So they thought, Galen had some ideas of the blood being created in the liver. And at the time, they initially thought the pancreas is toward which all the lymphatics were going. So then we had Rudbeck, that really was the first one to really systematically explore the lymphatic of the body, where they go. He explored also the first one to explore lymphatic circulation of the heart. But Thomas Bartholin, at the same time, wanted to take the priority, but it was actually Rudbeck who discovered them. But Bartholin was very famous, knew the King of Denmark, and called them the lymphatic vessels. So just a very quick history. So let's go into blood circulation. It's a very, very huge organ. It's about 100,000 beats per day. So the heart beats 100,000 times a day. You have an enormous amount of fluid that circulate, 1,500, 2,000 gallons per day of blood circulating. It's enormous. And you probably know, but in comparison, the lymph that you see on the left side, starting with a very one-way endothelial cells, with very little basement membranes, you start to see the lymph coming up through the thoracic duct, through nodes after nodes, and through the thoracic duct. And you only find 1.5 to sometimes 2.5 liter per day in the thoracic duct. So people thought it was it's not a very important system. And if you think that, you can leave the webinar because it's nothing, 1.5 to 2.5 liter per day compared to about 7,500 liter per day in the blood. So we slowly understand the importance the importance of the lymphatic system. But for me at school, it was very minimized. It was not important when I went to med school. So as the lymphatic system, so you have little cells, and then you have the lymphatic system, the first initial lymph capillary. Oops, I don't know how to go back there. Yeah, here it is. The first initial lymph capillary right there, or initial lymphatics, start at a blind alley like this. So do you think we should call this a lymphatic circulation, technically? I like those little questions just to make you think a little bit. Do you think the lymphatic system is a circulation? Does it make a circle? So if you take into consideration the blood is going into the tissue and leaving with the lymphatic, that's a circulation. But if technically only look at the lymphatic system, it's not a circulation. We shouldn't really use this word. We could use a fluctuation or a word like this. So the basic anatomy, you have these blood capillaries. From the blood capillaries, we have a lot of component of the blood that leaks in the tissue every day. At the end of the day, you may leave maybe 75 grams to 100 grams of proteins are leaving into the tissue. These proteins need to be recovered. And now, a very, very simple question. What percentage of the fluid escape from the blood capillary? And, well, it's a bad question. Sorry, I wrote it this morning. From the fluid that escaped from the blood capillary, what percentage is recovered by the lymph? And what percentage is recovered by the veins? And 10 years ago, 15 years ago, just to give you a hint, and you can write it on your chat. Huh? They used to say that the veins recover 90% of it, and the lymphatic 10% of it. And that was not even part of the starting equation. Do you know how much the lymph recover? We get one good answer already. 99–100% of it. Some people don't know, and you can see the reference at the bottom. There is almost nothing recovers by the veins. Do you remember filtration, reabsorption? We used to do that. So the reabsorption into the veins compartment, most of it is recovered by lymph. If the lymph was not working, we probably die from ototoxicity and massive swellings. So we recover most of these proteins. It's a lot of protein. I think we have about 250 grams of protein in our body. 100 a day is a lot. That leaks 75 grams, 200 a day. In the lymph, we have about 10 to 60 grams per liter, but it recovers all that, and only the lymph can do that. And you could see, let's go there. This is the initial lymph capillary. You have the cells in orange, and the openings between the endothelial cells of the lymphatics are enormous. They are about 6 to 7 times wider than an opening you would have on the venous compartment. Because on the venous compartment, you have a basement membrane and little openings, windows to let anything coming in. The lymphatic can recover large molecule, can recover fat cells, can recover, all kind of things, fat, not cells, chylomicrons and things like this. So these openings are very important because the lymphatic can do a job the veins cannot do. On top of it, we have a rhythm and probably a sucking effect entering the lymphatics. So if something is stuck in the tissue and is wide, definitely the venous compartment cannot recover this component. So you have one more. So you have not just lymphatic, you have flow. PL here will be pre-lymphatics. You have non-organized pathways of fluid in the tissue. And that's what happened in embryology. You have preferential pathways of fluid around which cells come around and eventually create vessels. CL is probably collectors, vessel. So on the left, you have the real organized lymphatic vessel. If you imagine rain on the roof, the rain on the top of the roof go through preferential pathways, disorganized pathways. Once they enter the gutter in your roof, this is your lymphatics. You have one direction, you have organized pathways, going with cells around it. So you have pre-lymphatic pathways, the tissue channels that are very small, and you have next to it, they're going to be absorbed into lymphatics very fast. In blue, lymphatics in blue there. So those initial lymphatics or lymphatic capillaries, they have 100 to 120 micron in diameters. It can be, depending on the area, wider or not as wide. And you have around them those little hair there that are called anchoring filament. And I will talk about that later. This is one endothelial cells, and they are called button-like junction. This electronic microscope photo shows you that opening, but is much wider than what you have in the blood compartment. Now, first connection with the fat and the lymphatic tissue. The lipids entering the lymphatic circulation do not go through the liver. They are not metabolized the same way. They are going straight to the heart, they're going to merge at the large veins at the base of the neck, the brachiocephalic junction, but so it doesn't go through the liver. So what is absorbed through the lymphatics doesn't go through the liver, through inferior vena cava, for example, or superior vena cava. So it's a different pathway. You have those open junction, about 2 to 3 microns, and you have those anchoring filaments that you can see here. L is a lymphatics, and H is a blood vessel. You have those anchoring filaments that are not collagen fibers. These are pre-elastic fibers. They are called oxytocin fibers. They are going to connect to the elastic fibers in your tissue, which tells you every time you breathe and every time you stretch, you move, maybe palpate with your hand and do a stroke, you can influence from the surface with the rhythm of your hand a movement in the lymphatic vessels under the skin because of this anchoring filament. Another structure which are specific of the lymphatic vessel that we do not see in the veins and arteries. So in this article from 97, you can see that the anchoring filament are going all the way to the skin. You have the epidermis and the dermis, and you can see that you have connection through many surrounding organs all the way into the skin there, right? Let me see one or two questions. So before I go further, if the protein lost by the blood vessel are recovered by the lymph, and someone has lymphatic insufficiency, would that contribute to higher need for protein in the diet? Actually, not necessarily. I'll explain that a little bit later. So you can see a rhythm here. So you see that some of you are practitioners, and we talk about craniosacral therapy, and that's a movement we don't scientifically yet have proven the origin of a cranial rhythm. But the lymphatic rhythm is a fact of science. You can see it in electron microscope, and you can see these large, now you have pre-collectors and then large collectors that collect the lymph. They are called monoliform, or if you want, as I live in Arizona, you call that a little sausage. But you could see some contract already, maybe here, they're contracting. You have those contractile units, and some are not contracting here. And those contractile units has been discovered in 1961 by Leslyn, and we still describe the lymphatic system as a passive system sometime, and you have to squeeze on it like you squeeze toothpaste. The fact is you want to re-stimulate natural lymphangial motoricity of these little muscular units. Okay, so imagine a peristalsis controlled by the autonomic nervous system, and that's the movement of your lymphangion. Lymphangion, angion for heart, little heart into the lymph system. So somebody asked me before, Catherine, you sent me by email, if we could maybe replace one day the lymphatic system who can help it with a pump. So imagine what happened in a crocodile. You are going to have one heart for the blood, and behind it, one heart for the lymph. In the salamander, you may have 10, 12 to 15 little hearts for the lymphatics throughout the body of the animal. In human, you have heart every one after the other along the lymphatic vessels. So to make a pump, you would have to replace all these little hearts because they are not tube, they are really strong. You have 2 to 3 layers of muscles around these lymphatic, strong muscles, and you have valve in between. So it's not easy, and the lymph is not a tube made of, a tube like the veins or the artery, let's say. You have valve, but also you have strong muscles around them, and you could see how beautifully they contract. Electron microscope, contraction of the lymphangion, the little muscular unit between two valves. Again, discovered in 1961. They are considered little pacemaker with their own automotoricity or lymphangiomotoricity, which make you understand why sometime after death, you can feel for half hour the lymphatic flow. If you are used to palpate it, you can palpate for 30 minutes, 20 minutes, an hour sometime, the lymphatic flow after death, because we have a pacemaker unit in this lymphatic system, right? And let me see if we can see from Zawicha in Texas, David Zawicha, this beautiful contraction of the lymphatics, slow, elegant, pushing the flow in one direction from valve to valve. This is the lymphatic rhythm in action. So one question for you: what kind of muscle do we have in the lymphatic vessels? In every physiology book, you have 3 types of vessels: cardiac, muscular, or smooth muscle. What type of muscle do we have in the lymphatics? Tricky question. Tricky question. We're not there yet. We don't have a right answer. It's not smooth, only smooth. Any other idea? With markers of the muscle we have and embryology, we realize they are a new type of vessel, having the property of heart muscle with its pacemaker ability, smooth muscle, and marker of muscular. So we have now a 4th type of vessel. That's the only place in the body where we find that. It's not yet in books because, as usual, people are very late to understand something with the lymphatic system or to update, but it actually should be a 4th type of muscle, lymphatic muscle. It's not just pure smooth, cardiac and smooth and skeletal. So this muscle, this rhythm, was evaluated and assessed by Olszewski in 1979, 1980, and 1981 in lymphology, number 12 here. So we know the contraction, the pressure it takes in human, and now it has been, we have like 600 maybe studies or more in animal and human. So again, this rhythm is a fact of science, right? So we do have a rhythm. It'd be nice to connect with it and enhance the specific rhythm of your patient. Just like diet or anything else, you have to adjust and help support the specific rhythm of your patient, of your client, and not just apply a rhythm without knowing what you can. And that is my contribution to the field, to help you palpate, because I'm an MD and an osteopath, to help you palpate the lymphatic, the specific lymphatic rhythm in the tissue. So we'll talk about that later. This is Olszewski, super nice guy from Poland. I found an old photo I took from him with in a seminar, in a convention, sorry. So this is one of my dissections of the human lymphatic system. We see already that those beautiful lymphangion, the largest collectors, lymphatic collectors, the largest lymphatic vessels in the body, including the thoracic duct if we want, they are very thin. And so we put a dye in that, we use a fresh cadaver, put a dye. Not only they're very thin, but they are most often embedded in the fat layer. In a limb, 60, 70, 80% of the lymph flow is above the fascia on the surface. So in the leg or arm, we have these lymphatic vessels really starting right under the epidermic junction, and we have it like here, right in the fat layer. It is not something that can break too easily because of that, but we do have to pay attention in lymphedema. When we have damaged lymphatic, we do not want to apply heavy pressure on that because they will break, and if you don't have lymphatic to evacuate your fluid, you will swell even more. We'll talk about that very specifically. And so those collectors ends up with the largest lymph vessels in the body, the thoracic duct, which is very, very, very small compared to the aorta or even the azygos vein. And we can see it terminate on the left side in this large vein, the junction of the subclavian vein and the internal jugular trunk vein. So it's called the brachiocephalic junction, usually the most common. All right, so it's going from the tissue, bypassing the liver, going to the thoracic duct, back into the superior vena cava, into the atrium of the heart, and then the heart can receive all the components that the lymphatic regain. Now you have a huge circulation in the liver. It's the organ with the most lymphatic fluid, and probably the first lymphatic anatomy described. But usually you don't need to go through the liver to come back to the heart. All right, we continue. What is this? Did you recognize this photo? Do you think is that lipedema or lymphedema here? So also you pay attention, it's a little bit more red here, right? And if you see that the fruit is swollen, it's asymmetrical. So you don't know without palpating, but this is typical lymphedema. It's asymmetrical. You have a little bit of heat there, maybe a beginning of inflammation, and while you have kind of a vasospasm sometime in the lipedema, and you have the cuff, but you have a very swollen foot, right? So that gives you some kind of more of a specific characteristic of lymphedema. It's a lymphostatic edema. What does it mean? The lymphatic vessels are static. They have been cut, damaged, or underdeveloped. We have a reduced lymph transport capacity in lymphedema. Not every edema is like this. If how do I say that? Imagine you have to build a beautiful castle and you have a very strong team, but you give them too much work. The workers are perfect, but you ask them too much, too fast. They cannot finish that castle in 1 week. Nothing wrong with the workers. And that could be an edema when you took a medication, you have a problem with your kidney or your liver or your heart edema, too much fluid coming into the tissue, you cannot evacuate it, but the lymphatic system is perfectly normal. This is not a lymphedema. This is a cardiac edema. This is a renal edema. When you have a lymphedema, this is the case when you ask people to build a castle, but you have 2 people working for you only. So it's not that too much job, too much fluid coming into the body. It's because you have a reduced lymph capacity. The lymphatic vessels have been destroyed, are leaking, or have never been developed properly. From birth, you have a primary lymphedema. So you have to see that something is wrong with the lymphatic vessel themselves to call something a lymphedema. If not, it's an edema. So mechanical insufficiency, sometimes called low volume insufficiency. All that explains the same thing. The lymphatic system is directly affected by that, all right? And we're gonna see that in the mapping. So if you look at this, this picture, It's not me, but it could be. No, I'm kidding. The lymphatic vessels are converging towards the axilla, right? The armpit. That's totally normal. If I see the back now of a lymphedema patient, so we'll talk about that later, we apply a manual lymphatic mapping, MLM. So we map the lymphatics, the superficial lymphatic here. That's what we need to do for lymphedema. You can see on the left, everything converges to the left axilla. Perfect. On the right, when we map, there is not only the vessels are not going back into the axilla, they have to go opposite. Some of them are going away from the axilla. That's why sometimes you have a lymphedema. Not every woman after surgery have lymphedema, but sometimes you can reroute spontaneously. Sometimes you cannot. This woman seems to have made beautiful pathway from this right axilla. She has an ipsilateral, same side pathway going from the axilla to the clavicle. Beautiful. She doesn't have one going from the axilla to the opposite or contralateral clavicle. And she has a huge pathway going from one axilla to the other. Posterior, axilla, axillary reroute. You don't have an axilla inguinal. So you look at this woman and you say, wow, she's making enormous, beautiful highways, evacuating the lymph over right quadrant, her arm and breast, towards the left. Two ways, one going to the same side clavicule, supraclavicular area, and one going to the contralateral, opposite side, axilla. She seems to evacuate. This woman may not be swelling, and she has natural, maybe after surgery, you say, well, there's nothing much to do. She has a beautiful spontaneous route. Or maybe that's what happened after your treatment. When you achieve these results after your treatment on lymphedema or lipedema, you are satisfied because you have two large reroutes that have been created. And for the rest of her life, this woman may have the upper extremity, chest, and breast draining to the left, to the opposite axilla, and to the same side clavicle. And so it's nice to know. So you don't want to damage the left arm. You want to really protect this arm, and especially this axilla. If you have crutch one there under your left armpit. What's interesting about the mapping, and we are going to talk about that, once you see this, you can have an idea of your treatment plan. Then you can have an idea of compression. Going back to the treatment plan, I am not going to force that lymph going to the inguinal. And so, you know, from an armpit, you have about 17 options where the lymph could evacuate. I'm not going to have the inguinal, ipsi contralateral. I'm not going to the opposite clavicule. I'm going where the lymph wants to go. That's the pathway of ease, and I'm going to help that. When that is put together, I can put a bandaging supporting this type of pathways. I can put kinesiotape supporting these pathways for lymphedema, and I can do movement from proximal to distal, maybe going from the left axilla, then movement of the paravertebral muscle, then the trunk, and then the arms, going exactly following, supporting this pathway. These are the pathways that you need, maybe doing a fleurage or skin brushing, dry brushing, following these pathways, right? And then I have a better idea, and checking at the end of my treatment and at the beginning of my treatment, if those pathways are still working efficiently, something changed or not. So that's the possibility we have by being able to map. Without that, we're pretty blind. We don't know where to send. And many teams just send the lymph everywhere they can, hoping one of them going to work. As just a little refinement to what everybody else did. Okay, the 4 most common causes of lower extremity lymphedema. This is a big classic, except in 2020, in January, a few months ago, we are completely changed in the cause of lower extremity lymphedema in America. What is the first cause of lower extremity lymphedema in the US? Exclude the parasite and things like this. What is the first cause in the US? Anybody knows? It's a classic. Nobody knows why we have lymphedema in America. Inactivity, sitting too much. Valerie Mills is very smart. Yes, it used to be surgery, cutting the lymphatics, mainly for breast cancer, for upper extremity, or for bladder cancer, ovarian cancer, for lower extremity. But right now, after this article, it is phlebo lymphedema. It is a venous cause. The second cause now is what used to be the first cause, cancer-related lymphedema. Third cause is primary, at birth, genetic. And fourth cause is lipedema, what's called lymphedema or lymphedema. All right, so don't forget venous obstruction, CVI, all the problem we can have with lymphedema in percentage. All right, let's go enough because we can spend, I wrote a 500-page book on the lymphatic system. So we're going to slow down with this and work on connection, specific connection, lymph and adipose tissue. Have you heard of that before? First of all, since Aceli, we knew that the fat from the alimentation, from your meals, is absorbed by the lymphatics. And you can see this line. Catherine, can you see my arrow for sure? Can you just move, yes or no? Yeah, you can see my arrow, yeah. So this is a mesenteric vessel, right? The lymph vessel is called the ileocholic arteries. This is the appendix vermiform, and you have just a little appendix vessel right in front of it that's going to join the ileocholic artery. These are going to go up to the superior mesenteric nodes. So this is absorbing all the lymph of the ascending, the cecum, the ascending colon. All that is going to go there. And after a meal, especially if you have a lot of fat, lipoprotein is going to come and make this lymph pretty white, right? By the way, this is a nice area to drain because a lot of kids with appendicitis, you just have to drain them for 5 minutes. That's exactly the direction I drain. And some of them don't need surgery. You just drain the appendix this way. But right there, after food, we know that the fat specifically, it can be absorbed by the lymphatic system. What is chyle, by the way? Cisterna chyli. Some people say Cisterna Chikly have nothing to do with it. Cisterna chyli, discovered in 1651 by John Pecket in France. What is chyle from Cisterna chyli? What is that chyle? You heard that all the time, the chyle. The chyle is simply the lymph, which is usually clear and transparent. That's why we need to inject a dye during dissection. And the long chain fatty acid, the chylomicrons, everything is lipoprotein, is reabsorbed and makes it a milky appearance. So it looks white, like milk. This white thing is a chyle. When you look in the same vessel, far, empty after fast or empty stomach, far from meals, it's going to be totally transparent again. All right. So this is something we know. We already saw in the dissection video. Lymphatic vessels are often embedded in fat. Lymphatic vessels absorbing fat from the food, and we found that when we begin to study that connection, the lymphatic vessels, if they have a dysfunction, they are leaking, they are broken, they have never been developed, they can be the cause of an obesity in rats. All right? So you can have obesity, inflammation, the role of inflammation from the lymphatic system, creating scar tissue because you have fibrosis, collagen deposit in the area. So adipose tissue, fibrosis can be created by an impairment of the lymphatic system. All right? Lymphedema patients have more adipocyte, fat cells, in the edematous extremity or tissue. And if you inject tissue with lymph, it's going to create a larger hypertrophy of local adipocytes. I'm trying to translate. Then, something interesting, lymphatic vessels are essential for RCT, reverse cholesterol transport. Basically taking the cholesterol from the tissue, bringing it into the plasma, and eventually excreting it from a fecal excretion, right? So this is an inverse of a deposit of cholesterol into your tissue, right? So you see you have different reference here. The net transfer of HDL, cholesterol, through human lymph is absolutely substantial. So what do we know? If we give a rat a very fat-laden meal for 9 weeks, the lymphatics of the aorta become distended. So the lymphatic is carrying all this fat from the food, and the endothelial cells have vesicle with fat droplet inside of them. So we can see now fat deposit of plaque in your arteries, atherosclerosis, and a problem with the lymphatic vessels. So I give you 3 quotes here. The first one from Gerald Lemole, he's a famous cardiac surgeon that really developed some few articles initially talking about this. So for the first time, the possibility that heart condition, such as ischemia, so lack of blood, and infarction, may be treated by direct targeting of the lymphatic vessels, all right? So imagine you have a heart attack, you have fat deposit, you have chronic phase, but in general, the cause of them, you have fat, so you're gonna help atherosclerosis, inflammation of these vessels that you're gonna help with the lymph system. And sometimes even they mention, like with ulcer, maybe there's a bug, maybe there's a bacteria or something involved. You can also help that with the immune system. So draining the lymphatic of the heart is something very important, and it's going to become more and more important to help treat any kind of acute heart condition, ischemia of the heart. So another relationship between lymphatic vessels and fat, they are really embedded and connected together. When I wrote my thesis in medical school, there is one study in France. It's not published, so I don't know if you have access. I think the woman was Ledoux or something like this. She took an ultrasound and drained every day for 2 weeks, something like this. And with the ultrasound, she saw the fat layer slowly getting smaller and smaller on most of her patients. Right, just a PT doing that and just draining every day. You can see and just measure with ultrasound the thickness of the fat vessel, and it was getting smaller and smaller, less and less inflammation, right? So just to give you an idea between the 2 conditions, right? Okay, so now hands-on. We're talking about hands-on. So who described the first specific manual techniques addressing the lymph system? Be great if you know the answer. Are you thinking Sumeria? Are you thinking the first technique, maybe Egypt? Are you talking African? I don't even know the African really medical. All those medical tablets were the tablets of clay of Sumeria, Sumer. But Egypt, maybe Ayurvedic medicine, maybe Chinese acupuncture. What is a traditional medicine that had specific technique for the lymph system? I'm not talking about Swedish massage. The Peter Link, you drain, but it's still an effleurage. It doesn't use a specific technique. The Roman, the Greek for the athlete has a lot of techniques. Do they have something specific that we know on the lymphatic system? Do we have something that Vinnie Varter, I don't know if you know, talk about working with hands-on on lymphedema. Who is the first known published or written technique addressing the lymph system? Specific technique, not just, you can say you drink a glass of water, it helps your lymph system. This is not a specific technique for the lymph. Trampoline is not so specific. Massage, effleurage. Who described the first technique? The guy was in America. Little hint. Anybody knows? Fuldy learned from Voder. Voder discovered some amazing technique, but who before Voder described techniques? You'll be amazed. His name is Andrew Taylor Steele. Any idea? Have you heard of this guy ever? Steele was the father of osteopathy. So I did a peer review article in the Journal of American Osteopathic Association. It's PubMed, you can find it. And the first description is actually from this man who developed many techniques. Just to give you an idea, because you probably never heard and you never explored this word unless you're an osteopath. This guy, first of all, influenced all the fascia technique, a lot of the chiropractor, because, you know, we think probably the chiropractor came to Kirksville to learn from him and then came back to Iowa, Davenport, you know, a few years later and started chiropractic. So there's influence on many, many techniques, the PT, the OT, the nurses, the chiropractor use today. And he wrote things like this: we're admonished in all our treatment not to wound the lymphatics. We have to handle them with wisdom and tenderness. I would totally agree with that. And your patient had better save his life and money by passing you by as a failure until you are by knowledge qualified to deal with the lymphatics. So if you're a massage therapist or an osteopath and you are not qualified to work with the lymphatics, you better close your door and stay home. So it's amazing. So after that, we had techniques. Emil Voder, as we know, Emil Voder was Dr. Voder, right? He was a doctor of what? Anybody knows? Everybody think he's a physician? What kind of doctor was Emil Voder? He got something in 1928, a diploma. Anybody knows what kind of doctor he is? No, he was not an osteopath. He was not a veterinarian. PhD of philosophy, 1928. So he started med school. He wanted to be a physician, but he got sick. He got really his condition, you know, his lungs. So he couldn't complete. So he went to South France in Cannes, and him and his wife, was it 1932 to 36, developed those techniques. They said on a lot of German clients that had a lot of thick lymph, the quality of the lymph. We'll talk about that later. The lymph can be very fluid or very thick. We want to check that out and saw little pearls and follow these little pearls and realize it was draining the lymph system. But because he was not a physician, he had a very hard time to be recognized. Initially, he went to Aesthetic Congress, and I think Asdonk in the 60s, 67, something like that, began to really explore and scientifically explore his technique, and we turn into MLD. So little humble me, no, but this is what I added to the field, and this is my book. So it's called Lymph Drainage Therapy, an osteopathic lymph technique. What I added to the field, and that's really what I can work with you, is to add specificity. And when you work for 20 years with the lymph, you know you can feel something. There's a little current, there's a flow there. And if you could attune to that, you feel, again, this amazing lymph rhythm happening all the time. With you or without you, this is what the body does, more or less efficiently, you know, in your body, everywhere you have lymph system, right? So you can attune. I'm going to show you how a little bit more how we could do that, attune to the rhythm of lymph. And I made a study with HeartMath Institute. I don't know if you know this HeartMath Institute in Boulder Creek, California. And at the bottom, you have the lymph rhythm. It's not correlated with breath and heart rate variability. The lymph rhythm is 0.1 hertz, very close to 0.1 hertz, which is an amazing rhythm that there's many, you can read many studies on 0.1 hertz, how this is a perfect resonance in your body for your baroreceptor, for your heart, for your immune system, for your cholesterol, cortisol, adrenals. It's a very important frequency for your body to beat. There's beating, there's contraction of in the brain, in the heart, in the digestive system. 0.1 hertz is very important. Bringing back someone to their own super duper 0.1 hertz is very good for health. So this lymph system has a very beautiful rhythm that you want to connect with. And so that was in my book too. And by the way, if you do cranial work, craniosacral work, this is the same rhythm of the cranial rhythm, the visceral motility rhythm. There's a lot of rhythm in the body at 0.1 hertz. All right. Once you get your rhythm, I want you to find your pressure. Are you talking the skin? Are you draining the muscles? Are you draining the pancreas? Are you draining the large intestine? Are you draining the pia or the dura? We talked about the meningeal vessels. That's another webinar I'm going to do next week and the week after with the National Lymphedema Network, the NLN, on the meningeal vessel. Where specifically do you want to what lymphatic vessel do you want to stimulate? Okay, you have to get the right pressure for sometimes the chamber of the eyes, right? And finally, very important, the direction, because we saw was that in pathology, we saw that with lymphedema, the lymph, but that's mainly the interstitial fluid and the lymph capillary that don't have valve, those can go in a different direction. Once you are in a collector, you cannot go anywhere else. You have one direction. But before that, lymph capillaries, interstitial fluid can go in opposite direction, and you want to learn how to reroute lymph. And you have to first check which part of the body has the wrong flow and to reroute in the correct direction. And this is what I really help the field with to get more specificity. Still, some people think we cannot feel that, and I'm going to give you a little bit more science about this. All right, so you feel rhythm, pressure, direction, then the quality. Is that a very thick, engorged lymph or very fluid? Hand technique has to be specific, duration of the stroke, segment of the stroke, like proximal to distal, etc., etc. So this is kind of the specificity I help with lymph drainage therapy, my osteopathic lymphatic technique that I think I started in Europe actually in the 80s. So this is a mapping, a superficial mapping, and I wrote 3 articles. The first one was in lymphology, that's a very light one. Second one is with the National Lymphedema Network, LymphLink, National Lymphedema Network. And the third one is a peer review article. I was happy to publish peer review. They promised there will be PubMed and CBI, but they were not. So I really have to republish because it's not a quality journal I wanted. But this is what I published, and it was peer reviewed, so it was good, but not, I tried to republish somewhere, something like this. So what I did, I asked people coming to my first level, my class, level 1, hey guys, have you seen what direction the lymph is draining on the sole of the foot? Yes or no? Do you know where it goes? If you don't, I want you to tell me, just like that, where do you think the lymph is going on the sole of the foot? Just first morning, people coming together, and I asked them, to drain. Then I show how to map in level 2, and I ask people that just learned from a class, they don't have time to integrate. Day 2, I say, okay, you map a little bit now. Tell me where you think the lymph of the foot drain. If you have not seen a chart, if you don't know where it goes, and you want to drain this area, and you get all kind of, first you could feel, watch out, you could feel superficial lymph, that's what I want, not the deep lymph, not superficial fascia, not the deep fascia, because if you're not trained, you confuse all those things. So stay with the superficial lymph. Where does it go? In the sole of the foot. You step on it, so where the lymph is going, and you have all kind of response. And the correct response is this. I don't pay attention to the front of the foot or the heel. In the middle, should have a watershed, basically almost midline, and the lymph going left and right. And out of 400 untrained practitioners, 11, I don't know how they found it, they were gifted. They says, well, I think that's what I feel. Maybe it's luck. The people from level 2, we have 393, and we have 245 correct answers. Now, those people just learned. They learned the day before, or some from them just got it the same day because it's not so easy. And obviously, we have a very strong statistical significance there. When you have such number. So now they felt something, and they felt something that corresponds to anatomy. So it's not that I don't hypnotize them. It's seeing people can feel, trust your hand, you can feel the lymph flow, its direction, its depth, its rhythm. And why can we feel it? One of the idea I had is when we have this contraction of the vessels, those large collectors are 100 micron, 600 micron. So the movement is a change of about 40 to 80 micron, right? So the change, so imagine it's connected to the top, to the skin, right? The skin is moving a little bit. You should feel a little movement in the skin. You have a movement of 40 to 80 micron. The question is, what is the threshold for people to be able to feel a change in movement? How precise is our touch, human touch? Anybody else? We can feel maybe IQ micron is too small. Can we feel 1 centimeter, half an inch? Can you feel, I don't know, how small a change can you feel with your mechanoreceptor in your hands? Human mechanoreceptor, how sensitive are we? Anybody? Any idea? You want to try? How many meter, how many centimeter, micron? Any idea how much we can feel? 20 watts. I need a measure. $20? We can 20 kilo, 20 watts. 20 microns? Very good. Just to give you an idea. 0.5 millimeter. Very good. So when we do study, there are peer reviews to do. So I went through all the database, and those are not even trained practitioners like a lot of us. So in the general public, just to give you an idea, an eye receptor can respond to 1 photon. 1 photon is enough to create an electric response in the eye, in the retina. Well, all the studies show 1 to 3 micron. That's how little we can feel. And one study came up in 2013. They determined human tactile discrimination extend to the nano scale. So don't limit yourself. We have amazing receptors. We can feel amazing things. And definitely a change of 40 to 80 micron, if you are trained, and if you're open to it, if you're not saying, oh, it's impossible, if you're open to it, I have 12,000 people that I train in North America. And in Europe and everything, I don't know how many we have total. I think probably 15, I don't know exactly. So we have a lot of practitioners, and you could see out of 393, 245 failed the mapping. So many people can feel that. Just stay open. Just know that you can feel to the nano scale with your hands. Don't limit yourself. You can feel a lot more than you think. Okay, so have fun with that. All right, so well, that's more technical. So how do we, once we map, you can, before the session, make your initial assessment, where you have fluid restriction, where you have stagnation, where you have fibrotic tissue. Then during the session, you can see what you do, if it's efficient or not. Hey, it's draining, it's not draining. I'm cannot reroute. And after the session, you can see your final, work, where does it go if you're happy with it. Then you can select your physical protocol for exercise, for your compression. For example, if you use some kind of sleeve with lines, groove into it, right? Kinesio tape, you know exactly what direction to go. And something that's interesting for lymphedema, also for lipedema, is we have in lymphedema a stage 0, which means after surgery, some people don't swell. About 25–30% of women swell after, let's say, breast cancer surgery. But you want to know, what are my risk of swelling? Can I play tennis? Can I carry heavy things? You have something called stage 0 when you don't see a clinical edema or lymphedema yet, because you need about 30% of extra fluid in your interstitial compartment. If you have 10%, you don't see it, but you have a hyper pressure if you measure that with lymphography. If you measure that, you have high pressure already in the lymphatics, but not clinical edema or lymphedema yet. So with the mapping, you already see that the lymph try to reroute. They cannot go to the axilla, they cannot go to the inguinal, they cannot go there or there. So this can help you determine already in stage 0, before anything clinic, that you need to work with this woman, reroute now, before they begin to blow up, before they begin to swell. All right, so that's one of the applications, and that's a superficial mapping, because the lymph go on the surface. Same thing with the heart, by the way. The heart go from the depths, subendocardial to subepicardial, from the depth to the superficie in the heart. The lymph is looking outside. Yes, pattern every 10 seconds, total. One way in, one way out with a tiny pause. Something different than keto. We can talk about keto after. So why does it help? That could be lipedema, but that's probably surgery. It's so complex. That's lymphedema, lower extremity on the left. So that's going converging to the inguinal. It's normal. You have part of the legs here that we don't know exactly if it goes or not. Oops. Part of the legs is going out. The abdomen on the right is going toward the left. I mean, the mapping really explains the confusion. If you train, you don't know where to go. You reroute this person and you let it's a special technique when you let the lymph route and choose where he wants to go. The lymph wants to go up. So the whole lower extremity on the right is now going to the same side axilla. So if we're inguinal, ipsilateral, axilla pathway. That's what IIA on the title. Inguinal, ipsilateral, same side, axilla. And that's a blue arrow after the treatment. And usually the switch can take a few minutes. It can be, take a short time. From now on, we know what kind of exercise we're going to give this person, how we're going to put kinesio tape, how we're going to put the bandaging. And hopefully we check next session, if it stays in place, etc., etc. Right? That can be the same for lipedema, if you have a special lipolymphedema. So you can see the 4 quadrants in the abdomen. Usually you have a belt, a watershed, an horizontal watershed at the level of the navel. The navel itself, if you have an infection from a ring or something like this, drain to the inferior quadrants. And you have here what the Utah, Colorado, Arizona, and New Mexico, right? The 4 quadrants existed in the human body before the USA. So those 4 quadrants, so you see at the level of the navel, look at what's amazing with mapping. This is a tummy tuck. With the tummy tuck, you take off the navel, you pull the skin down, and you reattach. And look, the 4 quadrants now are at the level of the scar, where not at the navel anymore, because that's where the lymphatic was draining before. So it's beautiful, where the lymphatic are now very low, going all the way to the axilla, and under is going to the inguinals. And we have 4 pathological modified quadrant now after surgery, right? And I did a study, only 1 patient with pecking in Paris, and they showed me a patient. We couldn't see if he was swelling or not. We had to check them. And I mapped this person, and you could see that the lymphatics are going medial toward the inguinals. And I didn't know. I just mapped. I didn't know the history. I didn't know nothing. And there I map, and oh, the lymphatic is going away. This is not going toward the inguinal. There's something wrong in that foot. You should always see the inguinal going from lateral to medial, rotating like the veins, slightly medial. So there's something wrong. So I said, there's a lymphatic problem on the left foot, and it starts very distal. And that's why, I wanted to do a lot of them. And we could see, that was my mapping, you have something wrong. I can't see myself because of the photo. Yeah, you have something wrong on one leg compared to the other legs. We put them under the gamma camera, and we saw, oh, stasis in the left lower leg. That's the kind of situation we saw. So that was the only experiment I could do. I could not continue, but it would have been cool to do that on that 20 or 30 patients. But it was very difficult because I was already living in the US, and it was hard, and picking was super busy. But I just did 1 patient's feasibility. It's feasible to do something like this. So now what is this condition? Imagine very beautiful small hip. Nobody gonna tell me what this condition is? Don't tell me it's COVID-19. I know everything is COVID-19, but it's a lipedema. You could see, that you have a cuff, you stop, and you have nothing on the legs, on the foot, right? Why don't you have something on the foot? Because you have very little fat layer on the foot, dorsum of the hand, eyelids, the penis. There's some areas when you have very little fat layer. So how can you, expect too much, adipocyte growing there? All right. So you know a lot about lipedema, sorry. You can see the foot are spared, and you have Stammer sign. So when you pinch the proximal phalange of the second toe in a lipedema patient. This is called the Stammer sign. Is it positive or negative? It's negative. Form Michel. That's a very smart one. She answered a lot of good questions. Now, what does it mean exactly? It means, yeah, it's negative. It means that you don't have lipedema. You don't have lymphedema, begin to be tired. You don't have swelling on this area, unless you have lymphedema. But lymphedema is not phase 4. Lymphedema can appear any phase, 1, 2, 3, or 4. It's usually phase 3 or 4, but it can appear. It's not just the same thing as phase 4. So you can pinch. You can pinch. You can take a little bit of skin. You can take a little of skin. That means there's no swelling. So it's negative. If you cannot pinch the skin, it's positive. You have a lymphedema or a lymphedema. Negative. Before any type of lymphedema. All right. Now, this is my mapping of lipedema patient usually. You have tortuous, sinuous, lymphatic. Question, must you always have ankle cuff? You have them if your lipedema is wide enough. What you have an area with fat deposition and an area with no deposition. So if you have enough fat deposition, you have an area where the fat stops and the foot without fat deposition starts, and you can create a calf. So very, stage 2, stage 3 usually have a calf like that. With Ehlers-Danlos, you can pinch skin anywhere on me. Oh yeah, with EDS, if you have hypermobile on the skin, with it. All right, so this is interesting because that tells me, my mapping tell me that the lymphatic maybe are going to be damaged here because they are squeezed, they are already compressed probably from outside, there's maybe a little bit of fibrotic tissue, something is wrong, most probably in the external compartment, interstitial compartment. Yes, and then tells me, very smart, who say, Wei Chen, yeah, I would not recommend just the Stammer sign, it's just an extra, I absolutely agree. Wei say, I would not recommend relying only basically on Stammer sign to diagnose lymphedema. It's just a sign on, during when you do evaluation. All right, so this is a lipedema typically, and you could see that in the literature, before I even read those, they describe the same thing. Lymphatic can be tortuous. You can find slower lymphatic flow, widening of the lymphatic vessels in lipedema, okay? So that's something that you could see, and if it's too tortuous, you really want to help drain that. And I'll talk about that later. Lipedema, it's so you know that. Adipofascial disorder, lipodystrophy, fat disorder. We have some genetic for some cases. Okay. So the cause, as Catherine said, is unknown. The hypotheses were few of them, but we don't know where the problems start. Estrogen, estradiol, the lymphatics are primarily damaged. Inflammation, the immune system is damaged, autoimmune disease, extracellular compartment, is it coming from the collagen fibers? Is this one of, part of EDS, a different type, or, fibrotic tissue? Maybe some people with some disease, Williams disease, I thought it was elastic fibers, that a lipid metabolism primarily. We talk more and more with microbiota. Is that a cause we don't explore enough? Is that a cause of, or a consequence? Often it's a consequence, but we don't know exactly. So we have a lot to learn. We have a lot of work on that. But we often have abnormal lympho. That's what we know. Again, we don't know if it's the cause or the consequence. And a lot of team are thinking, for example, that, is it a damage to the microlymphatic vessels initially? Or is it initially a damage to the connective tissue or to the adipose tissue? That's what we don't know exactly. So this is what I suggest with the treatment, okay? And I used a very old 1995, Eliska and Eliskova published something in Lymphology 28. Let's see if I have the, and they say something very interesting, because for me, you know, you have to do something on the fibrotic tissue first, right? You can work on self-treatment, absolutely. Because if you just, the lymphatic are trapped into fibrosis, the fluid cannot move so much. You have to release the collagen fiber a little bit, then you can move the lymph, right? Some technique do that. And the only thing I would say, and that's from Eliska Eliskova, here it is. Eliska Eliskova are peripheral lymphatic damage by high pressure manual massage. Didn't say drainage. Lymphology 95, 28, page 21 to 30. All my teacher and me, we know this quote by heart, because people see a ballooning limb, and they call that swollen lymphedema. They want to squeeze on it, which is not stupid. You know, the hydrostatic pressure is going to squeeze that and move the fluid. But with biopsy, Eliska, Eliskova, very nice people from East Europe. We see all these people in convention and congress. They did biopsy, skin biopsy, and they realized, number one, when you have a lymphedema or lipolymphedema, lymphatic are already damaged. And you could see that on the tortuous lymphatics of lipedema, okay? Lymphatic are already, we don't know if it's primarily the problem to start with or a consequence, but they're already damaged. If you apply heavy pressure on your lymphatic vessel, you are going to damage the few lymphatic vessel still working properly. And you're going to break them. So maybe for 10 minutes, you're going to apply very heavy stuff. It's going to help because the fluid is going to move again by hydrostatic pressure. But long term, you're going to have less lymphatic, which is going to create more inflammation, more fibrotic tissue, and you're going to have a very dry fibrotic area with very few lymphatic to evacuate. So my position here, be very gentle with the lymphatics. Few are left, and you don't want to damage the few lymphatic left when you treat, whatever you do. So yes, address the fibrotic tissue with all quadrivascular, any kind of work, but don't do anything heavy. So in my class, I tell them, you address the fascia, yes. First, try the lightest technique you can. Do you stroke a bit deeper, a bit longer? Stay with fluid techniques. When this doesn't work, because nothing's going to work, make the next step with more fascia technique, gentle fascia technique, heavier, until at the end, the worst you can do is to do like heavy skin rolling. This is the most aggressive, you know, or doing, you know, heavy pressure, breaking, moving. This is, you know, breaking the fibers. We want to break the fibrotic tissue, and you break everything, and you break the lymphatics because you want to break the fibrotic tissue. You're going to break the elastic fibers. So after this treatment, you can have the skin lagging, and you can break the lymphatics. So you feel good for a few hours, and later on, you're going to have a lot of fibrotic tissue coming back. So if you want to do some technique, address the fibrotic tissue, yes, address the fascia in the first stage, but, you know, first be the least invasive, then gradually more and more invasive. And at the end, you can use, only at the end when nothing absolutely works, you can use heavier fascia technique, skin rolling, anything you want to do, but don't start like this. That's also, I have that, you know, 5 to 7 anti-fibrotic techniques that are fluid technique, and then, you know, 5, 6, 7 that are fascia technique, and all of them are a hierarchy. From the least invasive, you start with that, and after a few sessions, you get more and more invasive if you can, but don't start basically with the most invasive technique. That would be a mistake, and that's supported by the article from Eliska Eliskova in 1995. So then when I release the fibers, the fibrotic tissue, then I can feel that, wow, the tissue is a bit more open. Now we can drain the lymph, maybe drain a bit of the venous, because we know we help the venous return to using my specific rhythm of that person, specific direction. Do I need to reroute? Specific depth, you know, I am at what depth? the thick adipose tissue may be pretty thick. So be clear with your depth. So you have to learn how to discriminate, and that's part of a manual therapist training, basically, how to decongest. I mean, when you put your hand on your stomach, you can feel your liver, you can feel your stomach. It's just under the skin, but discriminate. Am I feeling the superficial layer? Am I feeling the fat layer? I am on the epidermis. I am on the dermis. Am I on the stomach under it? I am on the, peritoneum. Where am I? The greater omentum. So just learn how to discriminate. That's the job of a manual therapist, an osteopath, the PT, OT, chiropractor. And then pay attention to the quality of the lymph flow. So basically, first fibrotic technique, yes, and then do your drainage. And this is, what is that? Oh, that's just to show you, again, just with the mapping, how initially this woman, the lymph is going up to the axilla. There's a blockage in the inguinals. And sometime when you were out and you let the lymph come back where it wants to go, and these are the vessels after the treatment, the dotted vessels, they want to actually go back to the inguinal. Maybe there's still something working pretty efficient there. So just see where it wants to go, and then those vessels have been freed. You free the vessels, the lymph vessels, and you can drain them now. And it's much, much more efficient. You reduce inflammation, and you help to release a lot of toxins from the body. In the fat layer, you have a lot of PCB, dioxin, mercury accumulation. That's why some of you also get tired after a treatment, because you can release a lot of treatment. So that's why Catherine is drinking something again in an aluminum can. So yeah, so watch out when you drain again. If you drain too much, sometimes you really want to drain the liver, because that's why things get stuck. To avoid side effect, we do a bit of liver drainage, it's very specific. And then for the treatment and your nutrition. So I'm not going to talk about nutrition because it's very specialized. I'm not as good as Leslyn about it, but also because I've seen a lot of people reacting to different treatment miraculously. In France, when I was 18, I was doing something called Aikido, and we had a lot of alternating people and Feldenkrais and Buddhists and monks and people doing, and we had the raw food at the time already, the raw food. And some people were treating with cancer with raw food. It was fantastic. And I don't know if you know macrobiotic. It was something, in America, it's called Kinsha. I forget the name of the guy. He came to America. Oh, yeah, it's going to come back. And that was opposite to raw food. It was everything cooked, no fruit, and he was creating miracle on cancer. And anti-inflammatory diet was making miracle on some, a lot of protein on others. Some people, today I've heard like this 300 or 500 people that only eat meat, no one vegetable, no one source of vitamin C except what you can find in the liver and things like that. And they feel fantastic. And people that eat completely vegan and feel fantastic. So talking about nutrition is a very long debate. And I think we need to have better way to assess different types. It would be great to have like a nutrition for your blood type, but something that really works. And we know you need raw food, you need cooked food, you need a lot of protein, you need something that's really, maybe with the microbiome, we're going to get that one day. We're still not so that precise, but one day I hope we can see, who needs keto, who needs, no vitamin A, and who needs something like that. Exercise, that's good for everybody. Anti-aging, good for your memory, good for everybody. If you can, go slowly and increase. And then when it's time to do surgical treatment, it's time for surgical treatment. But I think it's always my idea to start the least invasive to the more invasive. So always try conservative treatment, decongestive therapy, again, with two phases, addressing the fibrotic tissue and then addressing the fluid after that, because it can now flow through the different type of, through the fibers. And I think we're basically at the end. What is this? What is this? Somebody going to tell me what that is? What is this? Anybody? What condition is that? Can you see? So you see can you see that's red right there? I didn't see that. You saw a lot of red idea. This is the red I want you to see there. Exactly. It's a secondary acute inflammation cellulitis on a lymphedema or lipolymphedema. But you don't want to mess up, and it could be a CVI, but here you have a lipedema or a lipolymphedema or lymphedema, you have an infection. In that case, it's a lymphedema with an infection. You don't want to just improvise too much because there is some also cancer after lymphedema, short trips, and you have complications like this. So you want to just kind of, work with the therapist and know what he's doing for cases like this. And I think that's it. That's the end of my presentation. That was an hour and a half, a little bit, yeah, about. Perfect.
Thank you. Am I off mute? Can you hear me?
Yes.
I can hear you. Yes.
Okay. Thank you.
I'm going to stop sharing, right? First thing is stop sharing.
Yes, you can stop sharing. Thank you so much. Boy, was that amazing. I have to say, I have to go back, and I'm glad I'm going to have the recording because there are things that I want to understand better, but really so wonderful. And I want to give you, everyone, this is Dr. Chikly's Health Institute. It's in Scottsdale, Arizona. And this is his contact info, student services at chiklyinstitute.com, and phone and fax. And I will send this out in the follow-up email as well. Oh my goodness. I feel like some of the things that I've sat in conferences and tried to figure out as I've been hearing different things about endothelials and cells and how it all fits together is starting, I have to say, only starting to make more sense to me. It's very complex. It's a very complex system. And again, I feel that knowledge is power.
And you were able to answer a couple while you were giving your presentation. I was very impressed how you got a couple of those in there. I think we had one that went by from Dr. Wei Chen. He was asking, and several people were asking about, how to palpate and how to feel the lymph flow. And he was specifically asking how you can feel if someone has lipedema and you have a lot of layers of fat and connective tissue. How are you able to fill that such a small differential?
Training. I have, just to give you an idea, I thought I could not, we could not feel the lungs through the ribs, but we can have thousands of practitioners, and it's not me, from osteopathic technique, visceral manipulation, thing like that. We can feel the pleura, we can feel the fissure of the lungs, But I developed a class where I teach all over the world because everybody wants to learn how to work on brain trauma. From the soldiers from Iraq and Afghanistan, and we have 25% of our kids that come back, or they're completely depressed, they can't function, they cannot talk, or irritated, angry, divorced, or they cannot focus, or they cannot have headaches. So all those, what I described, are subjective signs. Having headaches, being angry, being depressed, cannot focus, can have no memory. Those are rejected by the Army because it's subjective science, so we don't have enough information. And I developed 8 or 9 classes to work on the brain, the gray nuclei of the brain, this layer of the cortex, 3-layer cortex, 6-layer cortex. And so just to give you, feeling the lymphatics is just the beginning. When you're advanced, when you're therapist, little by little, at the beginning it feels impossible to even feel the lungs through the ribs. But after many years, an advanced therapist today can tell you have a rotation of your left hippocampus. You have a problem on your posterior pituitary. And the explanation, there's continuity of fluid, there's a continuity of fascia in the body, you have a continuity of electromagnetic field, and our hands have an amazing field that can develop many frequency adapted to what you feel. There's many, as I said, many receptors, and we don't even have enough science to explain. We're doing even quantum medicine, but I tell you, I train thousands of osteopaths, and they invite me all over the world for sport concussion, for army, from car accident. It's so common for Parkinson. to work on the brain. So it's so much more advanced and people love it. To work on the lymphatics and the fat layer, you have to discriminate epidermis. There's no lymph vessel. There's no actually artery, veins. There's no vessel on the epidermis. Then dermis, and then you go slowly different layers and you learn, oh, that's a muscle, different quality. And oh, I am on a periosteum, and now I am on the bone, cortical bone, spongy bone, bone marrow, medullary bone. So this is a palpation skill by layer that you learn at school to go from layer to layer. Oh, that's a viscera. Oh, that's a bone, that's periosteum, that's medullary cavity. So that's something that you slowly learn. I think I have a little video from YouTube. I think it's 2 minutes. It's old, I did it like 15 or 20 years ago. If you want, maybe I could, let me see if I have something like that. Let's see that. Is that okay? Catherine, it's 2 minutes 40.
Yes, that's fine.
Okay.
Let's see that. That's on YouTube, huh? You can go on YouTube. Can you see it? Is it on or?
Yes.
Moving, 6, 7, yeah, I think we're moving. So in practice, if you want to connect and feel the intrinsic rhythm, the contraction of the lymphatic, it's going to take at least one level. The first level of lymph, slow, gentle rhythm. In the second level, after some time, you could begin to attune to the direction. Here, the flow is going toward the inguinal area. Toward the inguinal area. So in normal. It's going to take a little time to do that. But what we have, if you go close to the spine, is an abnormal flow of lymph and interstitial fluid. For example, in this area, the flow is going in a different area, but away from the spine. Oh, here. Away from the spine is normal flow. A lymph flow. Even for the periosteum. Its rhythm, the direction is going towards the spine. What happens when you have those pathological flow of lymph and interstitial fluid is the leg usually is limited in its range of motion. I never told this patient, but I know it's going to be limited. And you learn to open the inguinal, there's a whole little protocol, and eventually to be able to switch that flow. So I think I'm going to switch and reroute the flow now. Of this resistance, the lymph and interstitial fluid in the area eventually will switch to a new direction. And right now, it goes very fast. The flow switch is very fast. And the other one is now it's going away from the spine. And usually, when you do that, when the flow is not going the right direction, the range of motion can change here. Look at dramaticness. And I do that in this case, every day. But I don't have a barrier, it's just easy for me. And this can be applied to local pathology like that, or a lymphedema, or edema of any original. Could be even in the back of the eye if you have a trauma or any area of the body. Thank you. So I think a few videos showing different things like that, the neck, range of motion increase. It's not to be spectacular, it's just to show you something really happened physiologically when you reroute the lymph. When you reroute the lymph, it can go back where it needs to go. The inflammation release, the factor inflammation release with it, the macrophage may be reabsorbed, or whatever you need to be, the collagen fibers, the fibrotic tissue, something change. And you can see on the joint, the change in the joint, but you see the change in physiology. Oh, the lymphedema disappear, the lipolymphedema, is going much faster. So it's just an idea to tell you that you can make a change pretty fast, and then everything after that can be much faster. Now, just realize I could switch like this so fast because she did not have a fibrotic tissue. There is no fibrotic tissue stopping the reroute, so the lymph is very easily going to the other direction. So in that case, she reroutes immediately. But if she does not have a free movement of fluid and interstitial fluid like this, then you need to first do anti-fibrotic techniques from more gentle to more and more less gentle, to, more aggressive, then you can switch like this. And so rerouting, I already answered this question about rerouting. Obviously, the question is, how can you change the lymph direction because you have valve? The valve are only in the collectors and the pre-collectors. You have no valve in the lymph capillaries, and you have no valve in the interstitial fluid, the pre-lymphatics.
Yeah, and just moving on from that, because there are several people that are asking about different questions that have to do with the fragility of lymphatic vessels, of how delicate
Yes.
they are.
I mentioned that.
And specifically with, dealing with fibrotic tissue, dealing with that, but not harming the vessels. And so several people are asking, would a compression pump be harmful? What about liposuction, since the lymphatic vessels are all embedded in the fat tissue? Is that going to harm the lymphatics? So how much can we interfere in those tissues and still preserve the lymphatics?
Exactly. So if I massage you, Leslyn, if you buy me a ticket to Hawaii and I give you a strong massage right now, Leslyn, you will not, even if I hurt you a little bit, you probably won't bruise, and you probably won't, you have a little bit of pain. If I do roughing on you, probably, you have a little bit of pain. You won't bruise, you won't swell. So somehow it's okay. I didn't really break any of your lymphatics. You didn't swell, you didn't bruise, you're fine. So often the lymphatics are embedded in fat, so you can roll them easily. They have anchoring filament that's stretchable, and you have a certain degree of flexibility of a certain window to press on them. But what I said from Eliska Eliskova, once you have lymphedema, then you have a lot of few are left, and the lymphatic left can be very damaged. Now you want to watch out. What about debulking, which some doctors wish to do for large lobule? How will this affect the lymphedema? Same thing, any surgery, you're going to break your lymphatics if it's very done well, and you're going to, Now there's Hakan Brorson who do a specific liposuction for lymphedema. And when it's very big like that, it's not so bad. And his technique is probably one of the best. Brorson is Brorson, he's a very nice guy. I used to go to Congress, he was always next to me. So I was a manual guy and he was a surgeon, and we always talk, and we always have a connection. He's a nice guy. And I like his idea, because when he's really, really too advanced, he took a lot of the lymphatics and he put a compression. He has pretty good results. So I like that. If you really want to do, I would use liposuction from Hakan Brorson, and some surgeon in America learned from him. That was the first and probably the best type of liposuction for lymphedema. Training the heart. Actually, I'm going to do a class on the heart. I think we have we have the viscera. So we have 2 classes on the viscera, thorax, abdomen, and another class on abdomen, pelvis. Some viscera are very important to drain. For example, the cancer of the prostate is known to be a cancer with some deposit PCB inside, dioxin, influenced by that. You want to drain prostate, and that's something you can learn, how to drain prostate, how to drain, uterus, ovaries, bladder. But the heart, I want to do a special class on the heart soon. Maybe I wanted to do actually a webinar on heart and lungs for COVID, how to work on those.
Thank you, Dr. Chikly. As to belly dancing, please come back. It's good for the body and the soul.